Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AbbVie.
Hello, I'm Alan Irvine. I'm Professor of Dermatology in Trinity College, Dublin, Ireland. I want to welcome you to this program, which is entitled Exploring JAK Inhibitors for Atopic Dermatitis. Today, my colleagues and I will be covering through the details of JAK inhibitors as a class of drug, the data on JAKs, and then through a couple of cases where JAKs might be the most appropriate treatment. But first, let's get started on our first module, everything you need to know about JAK inhibitors for atopic dermatitis. JAK signaling is complex and many cytokines signal through JAK kinases. JAK means Janus kinase because it faces both inside and outside the cell. And here we have cell membranes represented schematically with many of the key cytokines involved in the pathogenesis of atopic dermatitis represented. JAKs pair up as either heterodimers or heterotrimers. There are 4 JAKs, JAK1, JAK2, JAK3, and then TYK2, which is also a member of the Janus kinase family. And you can see as we look at the canonical type 2 cytokines, IL-4 signaling through the IL-4 receptor, and further signals manifest through JAK1 and JAK3 heterodimers. Look at IL-13 with JAK1, JAK3, and TYK2. Tyrosine kinase 2, we tend to abbreviate as TYK2. If we look at IL-31, the key puritogen, that signals through the IL-31 stroke OSMR receptor, and that downstream intercellular signaling is through JAK1 and JAK3. If we look at IL-5, which is another canonical type 2 cytokine, it signals through JAK2 and JAK1. IL-22, which is responsible for barrier repair, relevant for lichenification, skin thickening, and expressed in subtypes of atopic derm, signals through JAK1 and TYK2. And TSLP, which is an epidermal alarmin. So TSLP, IL-33, IL-21 are epidermal alarmins. TSLP signals through JAK2 and JAK1. What you can see, there's a commonality. JAK1 is common to all of these, either heterodimers, that means 2 JAKs, or heterotrimers, 3 different JAK classes. JAK2 is widely expressed as well. Small molecule inhibitors of JAKs have some selectivity. They're not specific in the way that a monoclonal antibody will be specific to a particular epitope with really high specificity, but they do have quite differential selectivities. That is to say, some JAKs will selectively target at much lower concentrations JAK1 or JAK2 or JAK1 plus JAK2, whereas others would be more pan-JAKs. In our illustration here, we talk about abrocitinib and upadacitinib. These are quite highly selective on JAK1, for example, which you can see is widely represented in AD pathogenesis. Baricitinib and ruxolitinib will inhibit both JAK1 and JAK2 with roughly equal potency. So there are differences between the JAK inhibitors as they spread across this class. All of the JAKs have some structural similarities, so at very high doses, you will get inhibition of more than one. But the selectivity principle is something that we want to discuss here. So just to recap again, we've got abrocitinib and upadacitinib being highly selective for JAK1, ruxolitinib and baricitinib having JAK1 and JAK2 selectivity. Just to talk about the differential approvals, in the United States, the FDA has approved abrocitinib and upadacitinib for the treatment of atopic dermatitis. In Europe, both abrocitinib and upadacitinib are also approved, but also baricitinib is approved from 2 years and up by the European Medicines Agency for the treatment of severe atopic dermatitis in childhood and moderate to severe in adulthood. The landscape of JAK inhibitors goes well beyond atopic dermatitis, and this can be helpful or useful to know in if people have many comorbidities. So patients with atopic dermatitis are at risk of other immune-mediated inflammatory diseases, and they include alopecia areata, they include inflammatory bowel disease, amongst others. So if we look at the approval spectrum, upadacitinib is approved for rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, Crohn's disease, ankylosing spondylitis, non-radiographic axial spondyloarthritis, polyarticular juvenile idiopathic arthritis, and giant cell arteritis. So there's a wide range of approvals. Abrocitinib is just approved for atopic dermatitis. Baricitinib is approved for rheumatoid arthritis and also alopecia areata by both the FDA and the EMA. So if you have a patient who's got relevant comorbidities, these are some things to consider. For example, atopic dermatitis with a patient who also has alopecia areata, JAK inhibition may well be a more attractive option to treat both comorbidities at the same time. Or similarly, if somebody had rheumatoid arthritis and atopic dermatitis, there's the possibility of perhaps improving more than one disease state with that single treatment. And that may influence selection of treatment in those patients to make an individualized treatment plan, something that might work for more than one condition that's ailing them. Where do JAKs fit in the treatment paradigm? So I'm going to review both the AAD, most recent guidance, and the European guidance as well. So one thing to think about in atopic dermatitis, you can think of it a little like as a pyramid. So milder disease can often be controlled well with topical therapies, and there are many FDA-approved topical therapies in the United States. These include topical corticosteroids, calcineurin inhibitors, crisaborole, which is a PD4 inhibitor, ruxolitinib, a JAK inhibitor, roflumilast, another PD inhibitor, tapinarof, an AHR targeted molecule. These are all recommended by the American Academy, and they're all approved for use in atopic dermatitis. But if we look specifically then at systemic therapies for people who topical therapy is not working for, or who have very severe disease, you'll see upadacitinib and abrocitinib represented here relatively equally with dupilumab, tralokinumab, lebrikizumab, and nemolizumab, which is only approved as a combination therapy by the FDA. That's an IL-31 inhibitor through an action on the receptor. And the other three are biologic therapies, which act to inhibit either IL-13 in the case of tralokinumab and lebrikizumab, or IL-4 and IL-13 in the case of dupilumab. You will see that there's weaker recommendations here for other non-selective immune suppression, methotrexate, azathioprine, and cyclosporin, and you'll see and mycophenolate, and oral or systemic corticosteroids by any other route are not recommended for the use of atopic dermatitis. This is where JAKs fit in the American view of the world, equally there with other systemic approved therapies. The European stepped care mirrors the American one, and there's not any really significant conflict between them, other than to say baricitinib sits in this because it's been approved by the FDA. There's a graduated severity you can see on the right, going from mild to moderate to severe, and depending on the ages, some of these agents are approved for severe AD and some for moderate to severe AD. Hence, there's an element of graduation. You'll see that there's two up arrows for the JAK inhibitors, abrocitinib, baricitinib, and upadacitinib for more severe disease, and that's moderate to severe disease. And you'll see also the conventional therapies recommended a little less strongly. The cyclosporin has a slightly stronger recommendation in Europe that recognizes custom and practice over a few decades, and also in Europe sometimes approval for funding is not given unless there's been a trial of cyclosporin. So that explains some of those relative differences between the USA and Europe, but they're really very mild differences. Similarly, corticosteroids are not strongly recommended in the European guidelines. So thank you for joining me. Please click next for the next module, which will deal with the safety and efficacy data of JAK inhibitors. Thank you for your attention.
Hello, I'm Dr. Jonathan Silverberg, Director of Clinical Research and Patch Testing and Professor at the George Washington University School of Medicine and Health Sciences in Washington, D.C. Welcome to this module, Unpacking the Data on JAK Inhibitors for Atopic Dermatitis. So, we're going to be talking about a whirlwind of data, and we're very fortunate because we now have multiple JAK inhibitors available and multiple head-to-head studies that really give us important insight about not only how we can use these drugs individually, but how they compare with other agents that are out there. So first, let's talk about abrocitinib, which is a preferential JAK1 inhibitor. And all of the abrocitinib phase 3 trials have the acronym JADE and in their name. And these are data from the JADE Model 1 trial, which are a pure monotherapy study, no background topical therapies allowed throughout the study. And what we see here is showing you, easy responses and IGA responses. So investigators' global assessment score, proportion of patients get to clear, almost clear on the left. And we can already see by week 2 numerical separation of both doses of abrocitinib from placebo, with the higher dose being even more effective than the lower dose, and that efficacy continuing to widen out, where by week 12, about 44% of patients on the 200 milligram, the higher dose, achieving this IgA clear, almost clear, compared to about 24% for the 100 milligram or lower dose, and both highly statistically significant compared to placebo. Now, I love to look at the range of efficacy. So here we see the EASI 50 and then EASI 75 in the middle and EASI 90. And for context, that's EASI 50 is a minimal improvement in the EASI score, EASI 75 is a moderate improvement, EASI 90 is a major improvement. And what we see is already by week 4, the majority of patients who are getting response already sort of getting there by week 4, indicating a rapid response. Takes a little longer when we compare that with the kinetics of the EASI 75 response, where by week 12, there isn't really a clear plateau yet, certainly for the higher dose. And when we get to EASI 90 for both doses, also no clear plateau. But in all three of these different binary thresholds, we're seeing dose dependent improvements, highly statistically significant compared to placebo. And again, this is in a pure monotherapy phase 3 design. Now, when we look at the long-term effectiveness numbers across the long-term extension study, the JADE Extend study, of course, the primary purpose of these long-term extension studies is really to look at safety, but these can also be used to get important insights into long-term treatment response. And what we see is really high rates in terms of treatment response across the board, across all patients. But in particular, as shown here, is within that subset of patients who in the initial phase 3 trials were previously treated with dupilumab and were deemed non-responders, we can actually see that, well, on the left are those patients who were prior dupilumab responders. On the right are those who were prior dupilumab non-responders. And we see that in both of these treatment populations, both doses of abrocitinib were highly effective. And with the 200 milligram dose being even more effective than the 100 milligram dose. Now, of course, that subset of patients reflected on the right is particularly important because that's really where the FDA labeling and positioning is amongst those patients who had a prior inadequate response to another systemic or biologic therapy. And we see that even in this tougher to treat patient population, good efficacy or effectiveness responses with abrocitinib. Now, what about upadacitinib? There's now a lot of data and multiple, both placebo-controlled trials as well as multiple head-to-head studies. And here we're looking at data from the Measure Up 1, Measure Up 2 trials. These are phase 3 identically designed, again, pure monotherapy studies, no background topical therapies allowed in any of the treatment arms. And what we see is also this very rapid response out of the gate with both the 15 milligram and the 30 milligram doses, with the higher dose being even more effective and a little faster than the lower dose. And when we look at really a variety of different treatment endpoints, we see a similar phenomenon in terms of high rates of patients who are able to achieve these EASI-75 responses, IgA treatment responses as well. And with plateau happening somewhere around week 4 or so for the EASI-75 responses, maybe a little bit closer to week 8 or so, or perhaps even beyond that for the IgA clear, almost clear. Now, what about the long-term data for upadacitinib? Now, here we have placebo control out to week 16, and then there's a blinded extension period that goes out to week 52 and beyond. And again, primary purpose for these longer-term trials, usually for safety, but we get to have some very important insights into longer-term real-world effectiveness. And what we see is really high rates of maintenance of response out to week 52. Now, it's important to note after week 16, there is no placebo arm. All the patients would get re-randomized to get upadacitinib, but it's a blinded extension study. So those patients who are getting upadacitinib 15 milligrams would continue to get 15 milligrams. We get to see what happens when they're continued in that kind of blinded fashion. And likewise, for those who are getting 30 milligrams, would remain blinded to their dose, and we get to see what their efficacy or effectiveness is like when they're continued out to week 52. And we see high rates of maintenance of response for EASI-75 responses and proportion of patients who are getting to the IgA clear, almost clear with a 2-grade improvement. Now, what about baricitinib? And it's important to note abrocitinib and upadacitinib are FDA approved in the United States for moderate to severe atopic dermatitis. Baricitinib is not. It was studied for moderate to severe atopic dermatitis. It is approved outside the US for that, but officially in the United States, baricitinib is considered off-label for atopic dermatitis. But here, just to be comprehensive and balanced, we show you the data for the BREEZE 81, BREEZE 82, which are the monotherapy phase 3 studies for baricitinib, where we see a dose-dependent increase where that 4 milligram, which is the highest dose, shows the best efficacy across multiple different endpoints compared to the 2 milligram dose. When we compare, we don't have head-to-head studies between baricitinib and the other JAK inhibitors, but if we do that cross-trial comparison, these efficacy rates look substantially lower than the efficacy that I showed you previously for abrocitinib and for upadacitinib. Now, in terms of patient-reported outcomes, of course, everything I've shown you so far would be, the X-Marion Severity Index, the weighted average of lesional severity and extent, whereas the IgA clear, almost clear, is just focusing particularly on lesional severity. But we know that itch is the number one symptom of this disease, the most burdensome symptom of the disease. So what happens in terms of itch and other, patient-reported outcomes? And what we see here is significant improvements across multiple patient-reported outcomes, particularly if we look at the patient-oriented eczema measure. There's a subscore specifically related to itch. The first question of that patient-reported outcome is frequency of itch over the past week. And we see significant improvements in the patient proportion of patients who are getting or their endorsement in terms of the frequency of itch over time. Now, in terms of long-term data, we also have data for baricitinib as well, and where we see high rates of maintenance of response amongst those patients who, were previously being treated and continue on their treatment, particularly when you think about those patients who are on that 4 milligram dose, who get a good treatment response and continue on that 4 milligram dose out to, shown here, out to week 68. We see a nice stable curve indicating a good maintenance of response. Now, I mentioned that we are blessed to have head-to-head studies for the JAK inhibitors versus active comparators, so no longer just placebo-controlled trials, but against biologics as well. And so here we have an active comparator study. This is a double dummy study that looked at specifically abrocitinib, the 100 milligram dose or the 200 milligram dose, compared not only to placebo, but also to the on-label dosing for dupilumab amongst adult patients with moderate to severe atopic dermatitis. And what we see is a recapitulation of the results, highly statistically significant improvements, dose-dependent improvements for abrocitinib, 200 milligrams versus the 100 milligram dose, highly significant improvements compared to placebo. But importantly, when we look at In green over here, which is the dupilumab arm, we can appreciate that early on, especially by week 2 to week 4, abrocitinib is markedly faster in its onset of response compared to dupilumab. Now, as we expect with the biologics, they tend to be a little bit slower, but they sort of slowly but surely chug along. And by week 16, what ends up happening is that dupilumab actually overtakes efficacy-wise abrocitinib at the 100 milligram dose, and it sort of sandwiches between the 100 milligram and the 200 milligram dose, but it never overtakes the 200 milligram dose in terms of efficacy. Now, what about abrocitinib versus dupilumab when we compare particularly with respect to itch? And so here, what we're getting to see is the portion of patients who are getting a 4-point improvement in itch, which is about a moderate improvement in the itch scores. And we get same color scheme where abrocitinib in the high doses in the orange, the lower doses in blue, and then we have dupilumab as that active comparator in green. And what we see is that there is a markedly faster response for both doses of abrocitinib in terms of itch improvements compared to dupilumab. And while dupilumab sort of, in a sense, catches up over time to some extent, it sort of sandwiches in its efficacy between the 100 milligram dose and the 200 milligram dose. Now, after day 113, what you're actually seeing is what essentially is very wide confidence intervals due to decreasing numbers. So it's hard to have confidence in those estimates. But if we look at prior to that, we would say that the efficacy sort of sandwiches between the 100 milligram dose and the 200 milligram dose. Now, what about upadacitinib versus dupilumab? And here we see in a head-to-head study, these are data from the Heads Up study, where we see EASI 90 or EASI 75 on the left, EASI 90, which is a major improvement on the EASI score in the middle, and then EASI 100, which would be complete clearance of the EASI score on the right. And as we'd expect, the harder the endpoint is to achieve, everything shifts down. But any way you look at this, a highly statistically significant improvement and a faster onset of efficacy for upadacitinib in this study at the 30 milligram dose compared to dupilumab with the on-label dosing. And in particular, when we focus in on the EASI 90s and then even more so with EASI 100s, that delta between the two drugs becomes even more prominent. And while dupilumab, in a sense, kind of catches up to upadacitinib by week 16, it does not catch up at all when it comes to the EASI 90s and the EASI 100s, even by week 16. When we look at itch, we also see highly statistically significant improvements for upadacitinib versus dupilumab when we just look at percent changes of itch over time. Now, there have been several meta-analyses that have been published that have tried to do the cross-trial comparisons using apples-to-apples designs. These are the results of one that I had the privilege of being a lead author on that looked at particularly phase 3 studies, monotherapy, so no background TCS usage in any of the treatment arms. And what we see is this sort of relatively, treatment hierarchy here, where the maximal efficacy was observed across the different trials at week 12 to week 16 for upadacitinib at the 30 milligram dose, for EASI 75s, followed by abrocitinib, the highest dose, the 200 milligram dose, then upadacitinib at the 15 milligram dose. And then there's sort of a neck and neck tie between lebrikizumab and dupilumab, but they're approved labels, followed just afterwards by abrocitinib at the 100 milligram dose. Baricitinib and tralokinumab fall in, sort of the lower tier in terms of efficacy by week 12 to week 16. And there's this sort of relative hierarchy was shown for NRS4 responses, IgA clear, almost clear, Z90s, etc. When we look sort of in aggregate, and here what you're looking at is on the y-axis, 4-point improvements of itch, and on the x-axis, achieving IgA clear, almost clear. What we see is that the clear winner here is upadacitinib at that 30 milligram dose, which is showing up sort of diagonally to all the other agents as being more effective, both on itch responses as well as on achieving lesional improvements, whereas abrocitinib at the 200 milligram dose is neck and neck with the upadacitinib at the 15 milligram dose when it comes to itch responses, although upadacitinib at the 15 milligram dose may actually be a little bit more effective on IgA responses than abrocitinib. Although of note, when making these comparisons, aside from all the potential myriad differences between trials, importantly, the abrocitinib studies were conducted out to week 12, whereas upadacitinib and all the other trials were conducted out to week 16, which gives them an extra 4 weeks to achieve their efficacy endpoints. Now, safety wise, there's so much here to talk about. We don't have enough time to be able to go through it all. But common adverse events that come up would be acne across really the JAK inhibitors as a class, nasopharyngitis, although it's not really that clinically relevant. We do see blood CPK increases, although laboratory monitoring is not recommended for this. And then we see things like oral herpes and or even herpes simplex, herpes zoster as a class-wide phenomenon across the JAK inhibitors, and occasionally headaches can come up as well. Now, this is, those are the common adverse events. I think the things that keep us up at night or get us thinking about, patient selection really would be around the boxed warnings. And we know that there's class-wide, boxed warnings that were inherited from other JAK inhibitors, particularly the pan-JAK inhibitors in autoimmune disease and in gastrointestinal disease. And so these class-wide warnings have been sort of applied in a one-size-fits-all way, including to abrocitinib and upadacitinib. And so they're in the label. There's really no establishment of causality that abrocitinib and upadacitinib cause those different class-wide concerns, but they note that isolated events did happen in the trials. And so it's something that we certainly should be aware of and read through the package insert so we're able to be able to have that conversation with patients. But really, that class-wide labeling was inherited from tofacitinib, particularly in rheumatoid arthritis patients who are age 50 and older with additional cardiovascular risk factors. And I think it's important to have the appropriate conversation with patients about, well, how does that information even relate to them or not? Well, I know we took you through a rapid fire whirlwind of data. Thank you so much for joining. And click next for the next module for case consults in moderate to severe atopic dermatitis.
Hi, everyone. Welcome to this presentation on case consults in moderate to severe atopic dermatitis. My name is Yael Leshem. I'm an associate professor of dermatology at Tel Aviv University, and I run an atopic dermatitis clinic. And Jeff, would you introduce yourself?
Sure. Good morning, everyone, and thank you for your attendance. My name is Dr. Jeff Hu, and I am the chair and associate professor of dermatology at Virginia Commonwealth University School of Medicine.
We're going to start with a couple of case presentations, and we're going to kind of dig deep and discuss how we treat moderate to severe atopic dermatitis clinic patients in our day-to-day clinic. So the first patient is a 32-year-old man with atopic dermatitis who has been managing on non-steroid topicals and has previously had systemic corticosteroids as well. Now, he's not doing well, he's not sleeping well, he's embarrassed by his atopic dermatitis, especially on his hands and wrists. He works in healthcare and has to frequently wash his hands, which does not help his condition. So first off, Jeff, this is a patient you're probably very familiar with. How do you approach these patients? How do you assess them?
Yeah, so I think the first thing that I would do is kind of get a good gauge of how much of his body is affected with atopic dermatitis, right? If it's just limited to, say, the hands, especially in a healthcare worker, depending on what he has already tried, I might even just start with some topical medications first and foremost and see how he does. And then if he fails those topical medications, then we really start to get into the what do you kind of want to do next category. So I think for BSA is probably the first place that I start from. I think some other scoring mechanisms, such as EASI and SCORAD, I don't routinely do that in my clinic because it really just takes a long time and we often don't have that type of time with patients. I think there are other things to discuss during that visit. So unless I'm really doing it for a clinical study or a research report that I'm writing, I probably don't do EASI and SCORAD as routinely. Now, one of the really important things I want to make sure that we touch on are these patient reported outcomes, right? Because sometimes we as clinicians, we see their disease, we empathize with their disease, but we don't live their disease, and the patients really do. So when they live with their disease, they should have a lot of input in terms of how are they doing. So I really like using things like the patient-oriented eczema measure, for example, just to make sure that we're capturing those different domains of how are they sleeping, what's their quality of life, are they able to accomplish daily activities. especially with this individual, for example, right? Having eczema on involving their hands can probably really get in the way of what they really have to do on a day-to-day basis. Do you use anything else, Dr. Lesham, in your clinic that might be beneficial in terms of evaluating this person's overall disease burden?
Well, I fully agree with what you said. I mean, we have to be feasible in day-to-day practice. We have limited amount of times. Every country has its own time, but I think one thing is common. We don't have enough time with these patients. I'm a big fan of the ADCT, the Atopic Dermatitis Control Tool. It's a really simple questionnaire, 6 questions. Patients fill it out while I, write down the note. And it really gives a very holistic view of the effect of atopic dermatitis on multiple domains of health, not just itch and not just a rash, mental health, day-to-day activities. So that's something I like to use.
Yeah. And I think these are really good tools to track their progress over time as well, right? Because I think visually we can see that they're improving, but are they improving from the most important aspects of their disease, which can be captured by things like the ADCT or the poem?
Yeah, and some patients really like to see the numbers. I mean, they know they're doing well, but if they see the ADCT has gone down from 15 to 6, it makes them, kind of gives a stack of approval to their improvement. Yeah, for sure.
Absolutely.
So let's go back to this case. This patient has significant disease. He has a BSA involvement of 20% of his body surface area, so probably much more extensive than just the hands. An IGA, Investigator Global Assessment of 4, which is severe, the highest score, and an NRS itch of 8 out of 10. So, what do you think? Is this a patient for systemics? Do you want to continue with topicals?
Yeah, I think with that amount of BSA, we certainly would be in the camp of starting a systemic therapy, right? We're living in the golden age of atopic dermatitis where we have so many therapies to our disposal. I think gone are the days when we used to tell patients we have phototherapy, we have methotrexate, we have cyclosporin, we have mycophenolate. Those are really old systemics that we are really using very infrequently now, given the golden age of all of these medications that are currently available. In terms of biologics, we have 4 different choices that we would present to the patients. We have dupilumab, for example, which is probably the oldest and the grandfather of all of these therapies. First came out in 2017 in adults, and then eventually now down to 6 months of age in children. We also have lebrikizumab and tralokinumab. Both of those are IL-13. Um, they target IL-13 molecule, and they are both FDA approved for kids over 12 years of age. And then finally, we have nemolizumab, which is a different mechanism than all the prior 3. And this one is an IL-31 targeting this type of cytokine that we colloquially refer to as the itch cytokine because we know that it has a significant impact on itch. Now, there are other oral medications as well for those that may not prefer a injectable medication, such as the ones I just mentioned. These oral JAK inhibitors include abrocitinib and upadacitinib, both of which are FDA approved in the United States for kids over 12. And then outside of the United States, people have access to another JAK inhibitor called baricitinib. Baricitinib is only available in the US for alopecia areata, not available in the US for the treatment of atopic dermatitis. All of these therapies now are on the American Academy of Dermatology guidelines for use of medications or systemic therapies in patients who have more severe atopic dermatitis. So typically, if I am talking to the patients, I will describe all the therapies that are available and I will tell them what the current guidelines are in terms of these therapies, all of which have the highest rating in terms of safety and efficacy. Dr. Lesham, anything you want to add in terms of your discussion with therapies to these patients, or how do you like to present in your clinic?
I mean, it's really, I feel the same that you have all these options and we're so happy with them and it's great. All the guidelines, the American Academy guidelines, the European guidelines, our local guidelines, I think there's something very smart, and that is put all these medications together kind of in the same line for moderate to severe atopic dermatitis. And that's great because as clinicians, we want to have our options available to all patients and open. But this does necessitate this really complicated shared decision making discussion with our patients and to really tailor the treatment per patient. And that's lovely. And that's what we do as dermatologists.
Yeah. I think there are some barriers to accessing these medications, right? I think depending on the age of the patient. So if I had a 6-year-old, for example, most of these therapies would not be available. And I think that discussions becomes a lot easier because you really have that one choice, which is dupilumab. If you have a severely needle phobic patient, then that also shifts your discussion a little bit more over into the oral JAK inhibitors as well. And then there are also other considerations, such as other potential side effects that they might be worried about. As we all know, some of the biologics, for example, can cause allergic conjunctivitis. So they have a concern about their eye, or if they have allergic conjunctivitis at baseline, that's something we may want to avoid. Versus if someone has a history of blood clots in their family, history of heart disease, history of cancer, most of us might be a little bit more wary about starting one of the JAK inhibitors. So, like you said, framing the discussion, figuring out what the patient is suitable for and most interested in is a great way of kind of getting into that conversation with the patient and figuring out what might be best for them.
Would anything move you more quickly towards thinking of JAK inhibitors as a first line medication? Which patients would that be a consideration for you?
Yeah, I think at least currently in my practice, most of my patients are probably still starting on an injectable biologic. And I think in the US at least, there are two reasons for that. I think number one is insurance coverage. A lot of our insurers, at least in my experience, prefer one of the injectable biologics over a JAK inhibitor for whatever reason. I'm not really too sure, but a lot of times they make you kind of step through that before you're able to get one of the JAK inhibitors. And I think the second one is when I have the conversation with patients over safety wise, a lot of patients do then lean towards biologics just because of that perceived lack of black box warning and the safety that they get from the biologics at the same time as these biologics being very effective. Now, for the patients that will probably do better with a JAK inhibitor, I think for my very severe, very severe atopics, I do know that from some of the data that have been published, especially by folks like Dr. Aaron Drucker up in Canada, for example. He has done this great meta analysis comparing the efficacy of different therapies. And JAK inhibitors, for example, do tend to perform better than some of the biologics. So I think for some of that population, I would probably jump to the JAK inhibitors first. I think for some of the younger patients as well, your 12, 13-year-olds that are maybe very needle phobic or hate the idea of getting a shot, I think an oral medication just seems to be more palatable for some of these patients to use as the first line therapy. How about you? Any thoughts that you have, or which patients do you see that might be more suitable for these oral JAK inhibitors?
Yeah, so I think something that I think you touched on is the issue of comorbidities. I know we are all generally, when we think of atopic dermatitis, we think of atopic comorbidities like the asthma, the rhinitis, eosinophilic esophagitis, and so on. And these patients will probably do, I mean, dupilumab makes sense as a good choice for them because it covers all allergic comorbidities. We do have to remember that some patients actually have different comorbidities, and some of them can be covered by the other JAK inhibitors, depending on each medication has its own additional indications. So that's definitely something to consider. And also from kind of an international perspective, the FDA black box is important. I mean, it changes the perception of patients. It's very important. It's key. But the European Medicine Association, as well as other local guidances, including in my country, they do not have a black box. So it's a different approach. There is this a more nuanced approach, I would say, that we have to consider. This may not be a great first line in patients 65 years and older. Obviously, patients who have relevant risk factors for cardiovascular disease, for venous thromboembolism, for malignancies. So you have to really pick and choose your patients, but it's not a complete contraindication. And then another thing you can do to mitigate that risk is just start low. So this would be my approach for most patients. And I used to be kind of a start high when we were using cyclosporin, start high and then go low. But with JAK inhibitors, I've kind of switched that around, and I feel very comfortable starting it with low dose. And I have had experiences. I'm sure you've had the same experience of starting it with patients who do not quite fit the classic bill, but sometimes you really have to move forward and help patients. And as long as you have an open discussion with the patients, explain the risks, I think that's fine. Yeah.
What do you like to tell patients in terms of expectations, right? Patients come to you and they have such horrible dermatitis and they're like, which one is going to work for me the fastest? Or how quickly should I start to see some sort of relief. What do you tell them? And if that's their question, does that sway you towards one mode of therapy or another?
So thinking about the kinetics of response, this is really where the JAK inhibitors shine, right? Their effect on itch is exceedingly fast. We saw it in the studies, but I think more importantly for us as clinicians, we see it in daily life. So this is really a matter of days. People stop itching. It's very impressive. And dupilumab, which is a great drug, it just works more slowly. And also the other place where the JAK inhibitors shine is reaching these really high, more rigorous endpoints when we're thinking about having really clear skin. So reaching those rigorous endpoints of no itch or no eczema, that's something where the JAK inhibitors do better. And this has also been shown in studies like the systematic review and network meta-analysis by Aaron Drucker and Karsten Flo, which you refer to. And I think we really see this in day-to-day life as well. So if this is of high importance to the patient, a high priority, this is definitely something to consider.
Yeah. But at the end of the day, right, like there are so many options for these patients. I mean, going starting on any one of these may not be the wrong choice for them. And then the good news is if one doesn't work, and I always tell them that, give it 3 or 4 months. If it does not work, there is another option that you can go on. And very rarely now do I have patients that fail, all the therapies, and we really still have to revert back to some of the older treatments.
Yeah, I think that's a great point. When I started out in atopic dermatitis, this was prior to dupilumab.
Yep.
I had an kind of a mentor of mine, an elder physician, tell me, "Why are you going into atopic dermatitis? It's such a depressive field. Like there's nothing, no way you can help these patients." And looking back at where we were then and where we are now, I think we're in a wonderful place. And just giving patients that hope. Even we have a plan, we have a next step. I find that's really encouraging to patients often.
Absolutely. So I think that was a great kind of framing of the available treatments that we have for that maybe biologic naive or for that patient that has terrible AD and is really coming to see a expert in atopic dermatitis for the first time. But now, we running these AD clinics, we end up having a lot of these patients who might have failed something already. So here is a case for you. This is a 47-year-old woman who has been taking dupilumab for her atopic dermatitis for a year and doing well, but she has developed head and neck erythema or dermatitis as a result of her treatment. Do you see this a lot? Like, if you had to give an estimate, what percentage of your patients do you think develop this type of head and neck redness or dermatitis after starting dupilumab? And generally, how long do we start to think about these patients as developing this after they start Dupi?
Yeah, so this is actually something that we do see. I mean, the literature talks about as high as 9% in some of the case years, so it's not uncommon. We obviously have to differentiate patients who had head and neck dermatitis beforehand and just did not respond in that area, which is a bit more resistant, versus patients who actually developed this new onset of head and neck erythema. But it's definitely something we do see. And it's very, very problematic. Patients find it very burdensome, which makes a lot of sense. This is a very visual area and it's a very prominent eruption. And then also, it's really surprisingly resistant to treatment. So if you try topicals, we try antifungals, thinking, is this malassezia? Is this allergic contact dermatitis? Is this Demodex? We've had so many thoughts about what's going on, and we don't know much. I mean, we do know now there's this great study showing this is a Th22 derived phenomenon, but still, we're often stuck. And patients can do really great under skin, but if they have this red face, this is a no go for them.
Do you have a sort of a tiered approach to how you approach these patients? Like you see somebody with head and neck dermatitis, is your immediate thought, let's move on to another biologic? Is your immediate thought, let's try treating it first? Any kind of diagnostic testing? Like what do you like to do in your clinic flow for these patients when you see them?
Yeah, so first off, I mean, I would kind of take a diagnostic timeout, even though I've been through it a lot and I've never come up with anything of substantial use, but I will go through the motions. So definitely ask for patch tests for allergic contact dermatitis after we do a good, allergy questionnaire, and try to figure out that approach. Do a good testing, use dermoscopy, use UV dermoscopy, look for dermatocytosis, which sometimes we can see in these patients. Um, I have tried topical and systemic antifungals, which have had some rapport in the literature. I have not seen much uh, um, success with these. I don't know if your experience is similar. And then usually try topicals, a bit of topical steroids, we switch to a topical non-steroidal. But honestly, usually we end up having to switch. That's been my experience. Has yours been similar?
Yes, very, very similar. I like your approach of patch testing. I think patch testing, because we do know that dupilumab can maybe shift that Th2, Th1 a little bit. So we do know that some of these patients actually develop more positive reactions. I almost always try an empiric course of oral antifungals. Dr. Matt Zeros a while back did a publication looking at oral antifungals for the treatment of head and neck dermatitis, not just in Dupy failures, but in all of AD. And he found about a 70-ish% improvement. I think my personal experience is not nearly as good, but I do see some improvement in some patients. Relatively low risk. I think it's a pretty safe thing to do. But you're right. Probably over half of these patients, I do end up switching. Now, speaking of switching, so the response to treatment here is her AD is much better, but it is not clear. And she has this head and neck dermatitis. What would you do now, knowing that you've done the diagnostics, you've done the patch testing, you've tried the topical and or oral antifungals, and your decision now is maybe we need to switch? What do you do now? What do you switch to?
Yeah, so this case really brings up two scenarios which can come together but can be separate. So one of them is that head and neck erythema, and the other is patients who respond to dupilumab or to other biologics, but they don't have that full response. So not itchy necessarily, or not clear skin. And these are actually two situations we definitely encounter in our daily clinic. So if I focus on the head and neck erythema for starters, there's several options. One great option would be a JAK inhibitor. JAK inhibitors have this broader mechanism of action, but they do block a lot of pathways, including the Th22 pathway. So it does make sense to use a JAK inhibitor in this situation. And we actually do have a bit of real world data. We have some case years and, actually over 100 patients already showing that most of these patients clear very nicely with a JAK inhibitor. That could obviously also help her eczema. And I've had that very good experience with that specific switch. There are other options we can consider. I mean, we've seen some, for example, with lebrikizumab, there's some data suggesting they don't do as much head and neck erythema. We don't have tralokinumab where I come from. It's not approved. I don't know if there's similar data for that. But there is this interesting study kind of comparing the response of face head and neck erythema to JAK inhibitors versus tralokinumab, which is an anti-IL-13 biologic. And for this specific indication, the JAK inhibitors seem to do better. And again, it makes mechanistic sense as well. So this would be a good option for me to switch to a JAK inhibitor and definitely, again, discuss with the patients the limited data we have on switching to other biologics.
Yeah, and especially since her AD is not doing much better, right? A lot of these patients are probably now maybe a little frustrated with the fact that they've been on a treatment for maybe 16, 20 weeks. They're having a side effect and they're not doing better. And the funny thing for a lot of my patients is they might be clear from the neck down, but if they have a rash on their face, they're actually less happy, even though they're now BSA on their entire face is a fraction of what their BSA was before. They're actually less happy about it because everybody can see that they now have eczema on their face. So for a lot of them, they want to switch. And then oftentimes the question is, well, biological JAK inhibitors, and I agree with you. I think going to a completely different mechanism of action, backed up by the real world data showing that JAK inhibitors, I believe, has a 90%, or more improvement in their head and neck dermatitis after switching from dupilumab, for example, can be a substantial benefit for some of these patients who just want their eczema to go away. Now, talking about switching over to JAK inhibitors, how would you monitor patients who are on JAK inhibitors? How do you do it safely, and what's your counseling like for patients who start this?
So the counseling will obviously start with a discussion we have with the patient, explaining to patients the risks, and that's a complicated discussion. Also considering that some of the more significant risks that are brought upon in the FDA black box, which we've discussed, really don't have a lot of real world data to support them at this point in time. So most of them are a bit more conceptual. They're kind of theoretical, and the data is a little bit conflicted. So it's definitely about bringing these forward. And then there's a lot of things to discuss. We have to really tease out patients who have, other relevant comorbidities. You have to do baseline labs and follow them up. And there's this great manuscript from the International Eczema Council that has, a lot of really practical, pragmatic instructions on how to monitor these patients. And then we really do these baseline labs. Really important to immunize these patients to get vaccinations. What we do in Israel is the vaccine for herpes zoster. It's an excellent vaccine. It's not live or live attenuated. And then also the anti-pneumococcal vaccine. So this is something we recommend to patients, especially since we have a very strong zoster signal with all the JAK inhibitors. And that's a steady signal that's seen throughout the lifetime of treatment with these medications. And then we just follow them up. So depending, there's no clear cut follow up time. It really depends on each patient. So it's anywhere between 4 to 12 weeks generally. That's when I follow them up as far as lab work. I will say one more thing about infections. We do have an increased risk of infections with JAK inhibitors. And this is mostly more kind of banal, upper respiratory infections and nasopharyngitis. I do counsel my patients on being just, a bit wary if you're going, if you're meeting someone who's unwell, maybe keep your distance. Be very more alert if you're ill, if you have a fever, if you're really ill, then maybe stop the JAK inhibitors for a few days. They have the really quick washout time. What's your approach?
So something very similar. I always do the baseline screening, exactly what is outlined here on the IAC guidance for JAK inhibitors. I make sure that if they are of the right age, they will get their vaccination for anybody over 18, for example. They will get all the live vaccines they need to do before they start the therapy. I stop it around the time they get sick. I stop it around the time of their surgeries, and then they can always restart afterwards because I want to make sure that they're not immune suppressed for any of those events. I check so I always do a 4 week check in. So I have patients start it, they come back 4 weeks from then. I will repeat some labs and then every 3 to 6 months after that. The question for you I have is, when do you get worried about their lipid panel, for example, right? Because sometimes we always see these slight elevations and we're like, don't worry about it. Probably not related, probably not related. At what point do you say probably related?
Yeah, so the lipid panel is actually, in a way, the easiest one for me. I struggle with the liver function test, but so the lipid panel, I think it is usually related. The question is what we do with it. So I would rather, if the patient is doing well on a JAK inhibitor, I would try to sustain the drug and then work through with diets or, with conventional lipid lowering medications in consultation with their GP. We do sometimes see some lab abnormalities. We see some leukopenias, some thrombopenias. We see some elevated liver function tests. Again, if it's minimal, we can just follow up. It sometimes resolves itself, but that's something we have to monitor for sure.
At what point do you consider someone a Dupi non-responder?
Yes, that seems easy, but it can be a little bit complicated because if someone is a complete responder, that's easy. If it's a complete non-responder, that's simple. But a lot of patients get these partial responders. Their itch is better. It's a 4. It used to be a 7 out of 10. They have a bit of residual eczema, but they're not clear. And then it really becomes a much more subtle game of figuring out what this means to the patient. So if a patient is very happy with the situation, that's totally fine. That's something we can continue with. And we have to figure out how much this, I would say, residual burden is really burdensome for this patient. And also, obviously, we have to let the patient know that he has options. So we do know we have a lot of great clinical trial data. Now we have a lot of great real world data from registries like the BioDay registry that shows that if you have a partial or non-responder to dupilumab and you switch to JAK inhibitors, you have a good chance of getting patients even better. So obviously, patients who did well with dupilumab do well with JAK inhibitors. That kind of makes sense. But also, these patients who are partial or non-responders, most of them do well with JAK inhibitors as well. So there's definitely a chance that we could get this patient to these high kind of disease thresholds of no itch and no eczema. So this is a conversation we have to have with the patient, and it's really interesting. Patients respond differently. Some patients are so happy that they're not clear, but they're not itching that bad, and they want to continue with dupilumab. And other patients want to switch and get that extra benefit. And for some patients, that extra benefit really translates to benefits in quality of life and in other measures. It's actually been shown in studies as well. So it's really all about figuring out when partial response is good enough for the individual patient. What's your approach?
And I like what you said about it's up to the patient, right? Because somebody can still be what we assess as having mild, moderate atopic dermatitis, and we know they can get better. But if they're very happy with the dosing, they're very happy with their current drug, they're very satisfied with how far they've come, I am not one to say, well, I think I can get you better. Let's switch you because God forbid something happens, right? Like they get worse or they have a side effect or something like that. I definitely let the patient lead that discussion. If they tell me they want to go to another medication that may be more effective for whatever, I will help you through that. If they say they're happy where they are, I will agree with you and I will, stick with you and I will see you back for, if things get worse or if you change your mind in the future.
So we're in complete agreement.
Yes, absolutely. Well, thank you very much, Dr. Lashem, for this great discussion. And hopefully, you all, as attendees, are now more comfortable using systemic medications in patients with atopic dermatitis and/or switching systemic medications in patients with recalcitrant atopic dermatitis. Thank you very much for attending.
Thank you, Dr. Yu.